I would like to thank Arthroscopy Society of Nepal, first of all, for giving me an opportunity to introduce one of the giant of osteotomies in India. He's none other than Dr. Bhusan Sabnis. He works in various hospitals, but at present he's in consultant orthopedics and complex knee surgeon at SportsMed Mumbai. Dr. Bhushan completed his basic medical training from University of Pune. He completed from University of Pune, India, and postgraduate training in orthopedics from Armed Force Medical Medical College, AFMC Pune itself, receiving the prestigious Brigadier K.D. Khare Gold Medal for Orthopedic Excellence. He then moved to UK for further orthopedic training, where he stayed and specialized, especially in knee surgery for 10 years from 2005 to 2015. He works as a consultant knee surgeon at SportsMed Clinic, Global Hospital, HN Reliance Foundation Hospital, and Hiranandani Hospital, Mumbai. He is a regular faculty in various national and international courses and is a specialist in joint preservation and joint replacement, sports medicine, and complex knee surgery. On behalf of Arthroscopy Society of Nepal, I'd like to thank Bhushan for accepting our invitation to speak on his topic. Thank you, Bhushan. You can take charge and start your presentation.
Okay. Can you all see and hear me?
Yes, sir. Yes.
Okay, excellent. Give me a second. So, good evening all. That was a very kind introduction by Dr. Joshi. I'm Bhusan Sabnis. I'm a sort of, I would call myself a specialist knee surgeon, but I'm a knee surgeon. In simple words, I don't do anything else apart from knees because I don't understand anything else now. It's been quite some time since I've just done knee surgery now. What we are going to talk today is about lower limb alignment and realignment surgery. I heard the last talk, it was brilliant, and I apologize in advance. There will be a bit of repetition from the last talk, but there's never a wrong thing by repeating a right again and again. So it will be a good thing to revise things quickly and keep things in perspective, so that I'll try and make things more interesting and easier to understand in terms of limb realignment. So we have seen a massive resurgence in joint preservation surgery. So in terms of disease epidemics, we are just recovering from COVID just now. In similar way, we had an epidemic of joint replacement from 1970, 80 onwards till about 2005 or 2010. Beyond that, now the epidemic is of orthobiologics and joint preservation. So we are now seeing a massive increase in interest by all orthopedic surgeons on lower limb realignment and how we can delay the primary total knee replacement or avoid that in patients with early or moderate arthritis. And secondly, we can also treat with realignment for various other conditions such as meniscal tear or cartilage problems and so. So without further ado, let's start with what I want to talk on, lower limb alignment and realignment surgery. So we have already gone through this, but there are a lot of complex terminologies that we use to denote a problem, and it's important that we follow a specific nomenclature so that it will be easier to communicate with your colleagues and your patients about the type of pathology you are treating, prognosticating the problem, and planning treatment for your problem. That's why we need to look at all these funny words that we are going to look at. I know this is repetition, but I'll quickly go through it. An axis essentially is a line that joins 2 points. Mechanical axis is when it joins the proximal and distal joint centers, and anatomical axis is the center through the diaphysis of the long bone. So that's the basic difference between an anatomical and mechanical axis. What we are built of is the anatomical, how we manage it is mechanical. So our body weight follows the mechanical axis. Anatomical axis is how the design of the body is. So the simple example of femur, the mechanical axis goes from the center of the hip to center of the knee, while the anatomical axis goes through the center of the shaft. So it's the line that we follow when we are nailing the femur, but not when we're doing a total knee replacement as such. So in tibia, fortunately, the mechanical and anatomical axis are almost the same, and they're considered the same for all technical purposes and planning of surgery. So similarly, the lower limb of the mechanical axis goes from the center of the hip to center of the ankle, and that is what we are mainly interested in anytime we are thinking of malalignment as a pathology and planning to do any corrective surgery as such. The anatomical axis is slightly varied. We won't go into too much of details of that, but the joint line is not perfectly perpendicular to the mechanical axis. It forms an angle of 3 degrees. And those of you who are into knee replacements will of course remember the 3 degrees of external that you add in to correct this change in the joint line angle. The anatomical axis is about 6 degrees from the mechanical axis, and it's further 3 degrees if we consider a line which is perpendicular to the joint line. So these are just basic things. These are not of great importance in our day-to-day practice, but it's something that should be on the back of your mind. So I heard the previous speaker telling you about these things, so I won't go back into that. It's simple: M for medial, L for lateral, A for anterior, P for posterior, and proximal and distal. Along with that, F is for femur, T is for tibia. When you use a small m, that becomes the mechanical, and small a is for anatomical, in simple words. So this is a very important image that is taken from Dror Paley's textbook for deformity correction. And Dror Paley was the guy who sort of reintroduced the concept of joint alignment and malalignment and these axes. Now, ignore everything else for purposes of the knee. We are only looking at these two angles, the MPTA and LDFA. Now, those of you who are keen-eyed would have seen an ALDFA. We don't use the ALDFA, we use the MLDFA. And the MPTA again is MMPTA, but since the tibial axis is same for anatomical and mechanical axis purposes, we always just say standard MPTA. And fortunately, both the angles are around 87 to 88 degrees. So it's easier to remember. Normal MPTA and normal LDFA are 87 to 88 degrees. And for the knee purpose, this is the only angle which is important, which is the anatomical, the posterior tibial slope or proximal posterior tibial axis. That's around 7 to 9 degrees, which we all know about. Now, most important characteristic in diagnosing a malalignment is having a standardized X-ray. So what we need is something called a standardized scanogram. So those of you who are watching this, take a picture of this and try and get this at your hospital or at your unit. This is what we essentially need anytime we are dealing with deciding about a deformity of the patient. So we want a standing X-ray. We want a standing X-ray of the patient's pelvis down to the toes in one single film, where the pelvis should be squared. That means there should not be any hip obliquity, and the limb length discrepancy has to be corrected. That means if one leg is shorter, you need to add in a wooden block or a book to correct that deformity so that both the legs are of equal height when we do the X-ray. This is the most important or key factor in deciding about a standardized imaging modality so that you can decide about limb deformity correction. So you get an image something like this, but make sure the X-rays are stitched together, make sure the joints are aligned properly, and the patellae are sitting in the center of the femur. It's a standard habit of radiographers and radiologists to look at the feet. So look at the toes when they're taking a straight line X-ray. So it's not the toes that should be facing forward, but the patellae which are to be facing forward when you're doing the X-rays. So every time I send a patient for scanogram, I always write in my advice note, advice scanogram, both lower limbs with patellae facing forwards, limb length discrepancy corrected, oblique pelvis squared, and with calibration. The calibration is required to decide on the correction when you're planning the surgery for any malalignment as such. Now let's talk about quantifying the deformity. So if I call you or you call me and we are discussing about a patient's scanogram, so it's easier to say what level of deformity is. So remember that weight bearing axis that we mark on the scanogram, the line which is joining the center of the hip to center of the ankle. If it goes through the center of the knee, this is about 50%. So that means that the line is bisecting the knee joint and there is no varus or valgus deformity. Normal patients, the line goes between 35 to 50, and this is the normal occurrence and nothing needs to be done. Anytime it goes beyond 50% of the medial tibial plateau, that's around 25% to zero, that means a varus deformity. When the line goes beyond zero into negatives, that's a severe deformity and the varus is significantly progressive. On the other side, on the valgus side, anything above 65 indicates a severe valgus deformity. Over 75, it's a severe, and beyond 100, it's a significantly severe deformity where the contralateral ligament is under significant stress. So, for example, if someone has valgus with a joint line which is going with a mechanical axis or weight-bearing line going somewhere here, that person will have significant opening of the medial joint line, i.e. the MCL will be under too much of tension and getting stretched. And opposite is true, if the line is going from the medial side here, they will have a lateral joint opening. And that you will see pretty commonly in our x-rays as such. I will not go into too much of details of the anatomy of the cartilage, but we know the cartilage is a once in a lifetime event with its typical trademark, typical arrangement of collagen type 2 fibers and distribution of chondrocytes. And after the age of 15, there's generally no healing. That's why anytime any injury happens, that becomes a progressive problem and it becomes a severe pathology as progression happens. Again, too basic, but we need to remember that knee joint is a combination of elbow. So that means you have the ulnohumeral joint as well as the radioulnar joint as a combination in the knee joint. So the medial side works as a ball and socket joint, and the lateral side works as a saddle kind of a joint. So knee is a complex joint with multiple range of motions. Another important concept is of knee adduction moment. So even in a normal person, the load on the medial side of the knee is generally higher as compared to the lateral side. So if you look at the way the ground reaction force occurs, ground reaction force is an equal and opposite force to the body weight that any person will have. So obviously a heavy patient will have a heavy ground reaction force, but at the same time, the more medial the ground reaction force falls, more pressure is on the medial side. Now, this force is called as knee adduction moment, or a KAM. And that's its essential factor that increases arthritis on the medial side. So anything which reduces the KAM or knee adduction moment is beneficial. Anything which increases the KAM will be damaging to the medial compartment of the knee joint. Now, if you want to go more into biomechanics, if you look at the adduction moment and plot a graph based on the gait cycle, in the stance phase, there is significant force happening on the medial compartment in the gait cycle, and it changes with arthritis. So in arthritis, there is significant increase in the forces on the medial side of the knee with progressive varus, muscle weakness, and progressive joint arthritis. A simple example is varus deformity, where the force is significantly increased because there is varus deformity and muscle weakness, which is contributing to the adduction moment. So if you look at comparison of a healthy control and knee arthritis, there is increase in the adduction moment as well. Now, if you combine the adduction moment due to varus and due to arthritis, you get a significant worsening effect. And with worsening arthritis, the cartilage damage also becomes worse and adduction moment keeps on increasing. So these two are the key factors, the alignment and the cartilage roughness or friction, which will increase the adduction moment significantly. And you would have seen patients who have severe arthritis walk funny. They have a weird way of walking, the waddling. And these are classically factors which are responsible for causing this circle known as vicious circle of varus arthritis. So a varus alignment leads to high adduction moment in the knee joint, which leads to further cartilage loss and further varus deformity, which further increases the adduction moment. So this is called as a self-fueling engine, and unless this cycle is broken somewhere, the alignment correction is not done, till that time this will just keep on progressing. So you have to break the cycle somewhere, and this is where you talk about correcting the alignment. Now, you traditionally have used various things to correct, right from using heel wedges or corrective foot orthosis, to strengthening the abductors in the hip to correct the adduction movement. One of the things that normally works slightly better is bracing. So the brace corrects the varus deformity and holds the knee in neutral alignment, but there is a limit to how much or how long a brace can be used. Uh, Unloader brace are fairly costly and have been used very commonly in younger patients who are active, and it has shown good correction of the uh, uh, varus deformity with reduction in knee adduction moment. But generally speaking, it's only a temporary process, and it's not something that would be used by the patient for more than 6 months to 1 year, maybe 18 months or so. So now we talk about how to physically reduce the adduction moment by doing an osteotomy. Now you saw those various angles that we discussed. So we know where the deformity lies now. Now 90% of the patients will, with a varus knee, will have a deformity in the proximal tibia, and that can be corrected by using various ways. Now the commonest way in which this is corrected is by doing a medial open wedge osteotomy, the planning for which is shown here. So what has been done is a line is drawn from the center of the hip to center of the ankle, and another line is drawn from the center of the hip to where we want the Mikulicz line to be, the weight bearing axis to be. So this is where the correction needs to be. We mark the new ankle center here. Now this is called as a hinge point where the osteotomy opens. You join these 2 points to the hinge point, and this is the correction that you're getting. And if you extrapolate this triangle from this position to this position, that is the amount of correction you need to correct the deformity and get the leg perfectly straight. So this is how generally, this is called as Miniachi technique of correction. There are various ways, of course. So mechanically speaking, it's a proven technique that osteotomy is going to reduce the forces on the medial side, and it will give significant reduction in knee adduction movement and pain in a patient, and this will cause the patient to walk much more normally. A common question asked to me is, do you actually feel that patients walk better with osteotomy? And the answer is yes, and it's been proven by various studies where patients walk almost like normal after doing a knee osteotomy as such. Now, let's have a quick look at how things are done. So, you need to assess the knee and see if there is valgus or varus. This is an acceptable scanogram. So you draw the mechanical axis of the lower limb, that's from center of the hip to center of the ankle. And we can obviously see this bilateral varus deformity, much worse on the left side. The Mikulicz point, that means the point at which the weight bearing axis bisects or cuts the tibial plateau, is about -20 on the left side and about +5 on the right side. So this is how we can quantify the deformity and talk about the severity of the deformity in a patient. You can also have early younger patients or with rheumatoid arthritis who have significant lateral deformity also can happen with recurrent with people who have patellar instability or genetically valgus alignment. It's a typical knock-kneed patient, and these patients will also need a correction of their deformity. I won't go into too much of details about tibial slope today. That's a slightly complex part of osteotomies, but you can also look at increased tibial slope in a patient on a weight-bearing lateral view, and you can do something to correct the deformity in that plane as well. Now, this is generally how, when you're planning a surgery, you see how much correction you are going to achieve, how much correction you're going to have with a deformity correction planning. So this is called as a trauma CAD software. And what you're seeing is pre and post image. Now, this patient has a severe deformity with an abnormal MPTA and abnormal LDFA. So this patient requires a correction in 2 planes, both femur as well as tibial. This patient was only purely MPTA problem. So when you plan the correction, it's going to be a perfectly straight leg with an MPT of 92, which is acceptable in my book. So this is generally how a surgical planning is done. Now, a deformity correction can be pretty straightforward, such as a simple HTO but you can be faced with severe deformity where you need to do a correction in both femoral and tibial planes. And that usually happens if it's a complex deformity. That's why planning is important and knowledge of these angles is important. Now, if you correct a deformity that is in the femur in tibia, you're going to have a really severely oblique joint line, and that joint does not work well. The joint will fail very quickly, and the patient is going to have more less than a couple of years of relief from the surgery. He or she is going to need knee replacement early. So whatever you do, make sure you plan the surgery in such a way that you get the alignment back to normal in both femur as well as tibia as well as a joint line. Sometimes in recurrent dislocation of patella, you need to do something to correct the rotational malalignment as well, and that also is important. Now, excessive femoral neck anteversion or EFNA is a very common thing that we see in teenagers and kids in the age group of 15 to 20, and they need a derotation femoral osteotomy to correct recurrent dislocation of patella. They also have patella alta and increased TT-TG distance, which need to be corrected as well. So a lot of things which can be done to realign the lower limb. So just to recapitulate, remember the MLDFA and remember the MPTA, both are around 87 degrees. Forget about the anatomical axis when you're surgical, planning anything surgically, we are dealing with the mechanical axis as such. So if you look at the PISA tower, it just needs an osteotomy to correct it and get it straight. And that's all that essentially would have been required. So those of you who have seen me or met me or know me, they would know my desktop looks something like this. So all patients who I see usually have a scanogram done, and there are hundreds and hundreds of scanogram on my desktop where I plan every surgery for every patient about how much correction is required. And it generally is a very good thing to correct a deformity properly. Now, let's talk more about surgical technique and surgical steps as such. So when you talk about arthritis of the knee joint or deformities around the knee joint, you need to correct around the knee joint. So there are femoral osteotomies and there are tibial osteotomies. You can have a medial osteotomy and lateral osteotomy. You can have an opening wedge osteotomy and a closing wedge osteotomy. So if you add all these combinations, you get 4 osteotomies around in the femur and 4 in the tibia, closing, opening, medial, lateral osteotomies. Along with that, there is a derotation osteotomy and a slope changing osteotomy. The former in the femur, the latter in the tibia, to perfectly align the lower limb. So all of these are important to know and understand. If I have time, I'll just quickly go through a couple of surgical steps. So this is a typical patient that is undergoing an HTO, but look at the severity of the deformity. Now, remember that adduction moment I talked about. Every time the patient bears weight, the knee goes into varus like that. And that is a culprit in causing severe progressive arthritis of the medial compartment. Normally, the osteotomy is performed from the medial side in the proximal tibia. We are talking of a medial HTO or opening wedge HTO through an incision such as this. Normally, a 4 to 5 centimeter incision is all that is required for opening the medial proximal tibia. A gentle dissection is performed to release the soft tissues. I usually don't worry too much about the saphenous neurovascular structure. I cut them. I warn the patients there will be a numb patch on the lateral side, and 6 to 9 months after the surgery, it will recover. And most are okay with that. Ready? The whole MCL is released. So the pes fascia along with the medial collateral, superficial medial collateral ligament is released in an L-shaped manner such as this. So you can see I'm making an L shape and I'm taking most of the medial structures in a single layer. You can see the layer getting raised up here with the cautery. And the key step in an osteotomy is clearing the neurovascular structures on the back. So as long as you are careful and not worried about damaging the neurovascular structures, you are safe. So that's a big curved osteotome that is going on the back of the tibia, and I clean the proximal tibia all the way to the fibula head. So you can see my periosteum going all the way to the fibula head, clearing everything on the back. And since it's flexion, everything just falls back easily, and you have sufficient place to do your surgery without any worry about it. So next is just putting a big human on the back of the tibia to protect the neurovascular structures and passing wires to our intended level of osteotomy. The level normally corresponds to the base cancerinous, so insertion of the semitendinosus and gracilis, and from the medial side is about 3.5 to 4 centimeters from the medial joint line, and on the lateral side is the fibula head. So this is how it looks normally on the C-arm. Now a second guide wire is now passed parallel to the first one, and it is pretty easy to do it once you get the hang of it. Once you get two guide wires, you got your array of K wires or guide wires to decide on the osteotomy. A simple trick is to make sure you are able to put the plate properly. Water assist patients with R small, so you need to adjust the cut in such a way that you are able to you are able to have sufficient space for the plate. That woman on the back is protecting the neurovascular structures, and I put on the distal part of the K wires. So whatever happens, I will not go in the joint. I'll always be distal to those K wires, and I'm using the seam to make sure I'm cutting the tibia parallel to the K wire, and I'm almost hugging the K wire as I go in. So there is no chance of going inaccurately either. Once you're done that, I normally do a biplanar osteotomy. That means I do one more cut under the patellar tendon at a different angle of about 110 degrees to the primary cut. All of this information is available in a book. I'll send you a link for the same. So if you do a good osteotomy such as this, your joint should open really easily. Now, these are Lambert kind of osteotomes, which are chisels as they're called, which are gently tapped in till the hinge point, and the hinge point is the point about 5 to 10 millimeters from the lateral cortex at the level of the fibula head. Now, once you're past that, you're stopping here. So you're about 5 millimeters short, and there is less chance of damaging the hinge now and opening the hinge. Now you're gradually opening the osteotomy without breaking the hinge. So this is called as stacking the osteotomy. So one osteotomy is stacked on the other, gradually opening the osteotomy, and you need to take long deep breaths when you're doing this. Give sufficient time for the bone to absorb the forces that you're subjecting the bone to, and not go fast in this. And this is how you are going to open the osteotomy from the medial side. You're already seeing the deformity is getting corrected. The medial side is gradually opening now. Now, once you do that, you will get an osteotomy which is stable, and the bone is opening and closing like a book. Now, that is generally a very useful thing and very nice thing to see on screen. If you're able to do that, you can see the hinge point is intact. You can see the osteotomy is stable and is opening and closing per your command. That essentially means you have successfully opened the osteotomy. Now, all that is left is opening it to the desired level of correction. So you want to open it to whatever decision, whatever your plan. In this patient, it was 11 millimeters. 11 millimeter paper clip is cut, and that's used to open the osteotomy to that level. And of course, there is another check that you will need to do. Remember that line I showed you that was falling somewhere here before. Now it's coming bang in the middle. I have corrected a bit more to about 57 to 60% in terms of the Miculis point to get my correction where I want. This is luxury, so I have easy access to bone graft, allograft that I normally use, and I pack it in always to make sure that I have a stable osteotomy, but this is not essential at all, so don't worry too much about this. Can you see this? Now, you make a small opening in the subcutaneous space to pass the plate in, and all that is now left is to fix it proximally, fix it distally, and get the plates securely fixed so that it can allow the bone to heal in the corrected position. Now, this is a tomofix system in which there is an additional step where you can actually compress the hinge. So if there is an inadvertent hinge fracture, you still don't need to worry about it because you're passing a cortical screw to bend the plate just distal to the osteotomy, and it gives a brilliant hinge compression which allows you to compensate for any hinge fracture that would have happened. And this is a great plate system to follow in every patient. There are various other systems which are smaller plates and can be done through a small incision. So this is my workhorse plate for general significant deformity correction as such. And you can do the whole 7 to 5 centimeter incision along with a small incision distally to fix the remaining plate. And this is a locking plate system. So that's how ultimately your limb alignment is now straight. If you remember how it was before, that's the plate fixed securely both proximally as well as distally with locking screws. There are 8 screws, 4 proximal, 4 distal. The center part of the plate is specially thickened to support the osteotomy as such. And if you remember how it was before, now you can see the leg is perfectly straight and aligned properly as well. And if you remember the preoperative varus that was happening with varus stress, that's gone now because the knee is now stable. That's the AP and lateral view where you can see the osteotomy is well open and fixed. This is a locking plate, so the plate never touches the bone completely, but is slightly proud by about 3 to 4 millimeters, and that is acceptable. That is absolutely fine. That's how it should be. So again, the key steps are passing the guide wires, passing the saw under the guide wires, opening it slowly with osteotomes, opening it to the desired level without breaking the hinge, and fixing with the plate. This is another system called as peak plate. It's a plastic plate which can be done through a small incision, and there are only 7 screws in there, and it's a smaller plate in size and can be used for smaller deformity corrections as such. So important concept is the hinge. So always keep your hinge at the proper position and always keep the hinge intact, and you will never have to worry about the stability of the osteotomy as such. Now, different patient, but about 3 months from the osteotomy, you can see the deformity correction is achieved. And this is the kind of activities a person can do once you get a good correction such as this. So it's a very gratifying surgery with brilliant corrections that you can achieve. What about femoral osteotomy? Femoral osteotomy is slightly tricky. Now, you always combine a femoral osteotomy to the tibial osteotomy in patients who have more severe deformity. Now, you can have a medial closing wedge osteotomy such as this, or a lateral opening wedge osteotomy such as this. So there are various ways that you can do. Either way, you're fixing it laterally or medially with a robust plate which allows the deformity to be corrected and limb to be realigned perfectly. I mentioned about a derotation osteotomy. I'll just show what a derotation osteotomy is. Essentially speaking, you are rotating the distal fragment externally to derotate the distal fragment of the femur. Again, you do a standard distal femoral osteotomy with a proximal biplane, and you put the bone piece that you take out to correct the valgus deformity at the same go. Fixed with the plate again. So if you look carefully at this image, you can see there is valgus correction. So there is varization osteotomy done because of the small fragment which is sitting on the lateral cortex, along with a plate which is holding the whole construct with derotation as well. So that's a brilliant surgery for patients who have recurrent dislocation of patella. You can make it very complex, of course. So those of you who are interested in complex deformity corrections, you see a lot of patients disabled because of this deformity, and a simple HTO will not suffice in such a patient. So in such a patient, you need to do something called as a TCVO, or tibial condylovalgus osteotomy, where you have to make a L-shaped osteotomy and open the cut in the joint as well, as you can see here, and you can get a perfectly aligned knee based on that. So this was the how the joint line was before, and this is how the joint line correction has happened. You can see the Mikulis point, which was sitting almost to the medial side despite a massive correction in HTO. But now that it's added TCVO, you can get a perfectly aligned leg as such. So what is important in realignment surgery is to understand the deformity, find out where the deformity lies, in which component of the limb, whether it's femur, whether it's tibia, and what correction is to be done. The books that I normally recommend are the Drawer Palace textbook of Principles of Deformity Correction and the AO Foundation book of Osteotomies Around the Knee. All the information I spoke is taken from these books, and I think this will take you on the right track to start limb deformity correction. Thank you.
Thank you so much, Bhusan sir. That was wonderful talk. It's always pleasure to listen to you. So there are some questions. I think we will go on with the case discussion. Some questions we'll be asking, and the questions which has been there in chat box, I'll be covering those during my talk. So alignment surgery of lower limb. This is introduction of alignment surgery. Our emblem of orthopedics itself revolves around the alignment surgery. So this alignment surgery dates back to very long time back. So this is very interesting slide. Bhusan sir also showed it. Alignment surgery means to correct the alignment, to correct the deformity, to correct the asymmetry in the nature. So as we have already talked, Dr. Bidur has already talked, these are the indications: age less than 60, purely unicompartmental disease, ligamentous stability, preoperative arc of at least 90 degrees. So Bhusan sir, what are in your cases, do they match all these indications? Like if the patient's age is more than 60 years, should we consider other than osteotomy in those cases? Bhusan sir. Hello? Hello? Am I audible, sir? Hello?
Jinx doctor, I don't know. I hear from this.
Yeah. They've just called me again. Hello.
Yes, sir.
Yeah.
So question was, is there something like age for osteotomy, like more than 60 years means we do not do osteotomy and all? Is there something like that, sir?
Yeah. Am I audible? I'm sorry, there's some issue.
Yes, sir. Yes, sir. You are audible.
So can I just take 2 minutes and talk just now? Is that okay?
Yes, sir. Yes, please.
So again, all of these are pure indications for a simple correction osteotomy, but things are moved on in such a way that you can sort of bend the indication slightly, except the stiffness, which is a key point here. Anyone with range less than 90, I would be very hesitant to do a corrective osteotomy. I have done HTOs for patients from age of 21 to age of 84 without any problems. Healing is never an issue despite elderly age also. Purely unicompartmental disease, yes, if you have, so you can actually titrate, or you can actually decide the amount of correction you want to do. For someone with a grade 4 arthritis in the medial side, you want to take the weight bearing axis well into the lateral compartment. But someone who has mild lateral disease also, you can just bring them to neutral and they're generally happy. Remember, I spoke about the tibial slope. So anyone with ACL or PCL laxity, you can change the slope of the tibia along with your osteotomy, and that will compensate for the ACL and PCL laxity. So you can even compensate for a ligament deficiency with your osteotomy as well. So osteotomy is very powerful surgery, and I, of course, won't advise anyone to start doing osteotomies for that straight away. But once you get proficient in doing osteotomies as a routine surgery, I think you can stretch your indications massively, and almost 50-60% of the patients that you would send for a knee replacement or do a knee replacement on are actually a good candidate for osteotomy. All of us knee surgeons in the world have now sort of come to a conclusion that it's important we delay the first primary total knee replacement in a patient to reduce the requirement of revision knee replacement. So all of these are joint preservation strategies which will allow the patients to have their own knees for longer time.
Okay, thank you so much. Yes, sir. That was very important message to delay the primary arthroplasty. So another question is, sir, purely unicompartmental disease is very uncommon. So we see the medial compartment or surfaces. We see some of the osteophytes in the lateral side and PF joint as well. So are they the cases for tibial osteotomy or alignment surgeries, or not the cases?
So generally speaking, any patient with lateral femoral osteophyte, you do not worry about that. As long as there is no central weight-bearing area damage in the lateral compartment, which is very rare in a medial compartment arthritis, you should not worry about the lateral side. So you always see that lateral hook osteophyte on the lateral femoral condyle, and you should not worry about it. About the patellofemoral joint, as long as the medial patellofemoral joint is the only one affected and the lateral is decent, I will not worry too much about it. Clinically, when you examine the patient, if the patient points to the lateral patellofemoral joint as the cause of pain, then you need to be slightly careful. That means your patient is not an ideal candidate for HTO as such. Patellar height is something which is often missed in all these talks and all these discussions. So if someone has patella baja already, a standard osteotomy is going to make it worse. So you need to adjust your osteotomy in such a way that your patella height doesn't get deteriorated or doesn't get worsened, and the patella baja is not worsened. BMI, height of the patient, activity requirements are all relative indications, and good counseling to the patient and good management of the patient's activities will sort things out, and the patient can still be a good candidate for osteotomy.
So my next question is, sir, what is the main indication for the osteotomy? Is it osteoarthritis or is it limb alignment? So we find sometimes the very well maintained joint space with mal-aligned knees, varus knees. So what is the main indication?
Funnily enough, this question is asked often. So the main indication for osteotomy is let's talk about HTO. So the main indication is a symptomatic varus deformity. So when I say symptomatic, it can be just an overload pain on the medial side. It can be early arthritis. It can be moderate arthritis, or it can be severe grade 4 arthritis as well. So any patient who has a symptomatic medial compartment overload or arthrosis is a good candidate for high tibial osteotomy to correct the deformity.
So confusion happens, sir. Sometimes most of our Asian population has varus knees. So what happens is there will be middle-aged female who present to us with bilateral varus knees, the Mikulicz line passing through the medial, more medial than the normal. So are they the candidate for osteotomy?
No. So anyone who has varus deformity does. So there is something called as constitutional varus. So all of us Asians have constitutional varus alignment. So that is not an indication for varus correction. Is symptomatic varus arthritis. So we are talking about symptomatic medial compartment affection, arthritis, or you are seeing signs of arthritis in the joint. So either the patient is getting significant knee pain with activities, there is significant medial overload, they're getting, someone has a medial meniscal tear, someone has a medial compartment condyle damage, and their activities are getting significantly affected because of this. That is a classical indication for medial compartment arthritis. Medial compartment arthritis is the main indication for correction by high tibial osteotomy.
Okay. Do you do routine arthroscopy, sir? Is it required or is it not required?
So Again, there are a lot of issues about this. I generally do not do arthroscopy for every patient that I do a HTO for, but if you start scoping every patient, you'll always see a meniscal tear. You'll always see chondral damage, and you always will have some small ganglion in the ACL or some loose body sitting here and there. So if a person is not having mechanical symptoms, that is, there is no instability, there is no locking, and there is no significant reason I need to do a scopy for, like someone has a root tear which I'm thinking of repairing, someone has a meniscal tear with a flap which is getting locked in the knee, I will not do arthroscopy. It makes surgery messy for no reason. Having said that, if a patient asks me to do arthroscopy, I will do it for him. There's no harm done by doing arthroscopy. It just adds 10 minutes to a procedure. But as long as you are clear of your diagnosis clinically, radiologically, and you plan to proceed with the HTO, I don't think arthroscopy is necessary. I generally don't advise scopy for every patient that I operate on. And there is no difference in the results. So if you look at the literature, taking a degenerate meniscus tear off will not have any role in result at 1 year, 2 year, or 5 years to a patient who has undergone HTO.
So, and looking after intraoperative correction, you always use alignment rod, or you all depend upon?
I think it's important. So it's as surgeons, we are always more conservative and more careful. So you always want to make sure that what you're doing is doubly checked. So there's no harm done. So I think if you're using a CM anyway, you have the alignment rods, why not just take 5 minutes and use it? So I always do it.
Okay, sir. Is there something like the Kelgens-Lorentz stage of osteoarthritis of knee above which the STO is not advised?
So traditionally, grade 4 HTO, grade 4 arthritis Kelgens, grade 4 HTO was sort of contraindicated. But so suppose a patient comes to you at the age of 40 with grade 4 arthritis with significant wears, what are you going to do? Are you going to tell that patient to sit in a wheelchair? So I think we need to understand that that person is only going to get 10 years out of HTO after decent correction, but still those will be 10 productive years. And as you know from literature or experience, a person with a TCAR done at 40 and a person TCAR done at 60 will have a massive difference in the longevity of the implants and the requirement of revision surgeries. So I think age is only a number. I would not worry too much about age and severity of arthritis. I will titrate my correction based on the severity. So someone with only grade 1, grade 2 changes with just overload type of pain, I will get them to neutral. Someone with grade 2, grade 3 arthritis, I will get them to about 55% of correction. And someone with grade 4 arthritis medially with a completely normal lateral compartment, I will push them to about 62%, the so-called Fujisawa point of correction during my HTO.
Okay, sir. So while correcting up to the Fujisawa point, what happens is patient will be happy with pain relief, but they will complain about knee being valgus. How is your experience about that, sir?
So to go beyond 60-65%, they are always unhappy cosmetically because the knee looks quite valgus. And especially when the one leg is corrected, they are generally women, they are generally very skeptical about the correction. But if you warn them previously that we are going to get they're going to get a leg which is slightly valgus, they generally accepted correction, and they're okay with that. But don't go beyond 60-65%. So my maximum limit is 62%. I won't go beyond that. So that I've seen X-rays with, or I've seen patients who go to about 70%. The medial pain is gone, but the lateral compartment undergoes arthritis very fast. So you don't go beyond 60%, I think.
Okay. Sir, and associated root tear and ACL tear, what do we do, sir? We repair a root always, or reconstruct in the same setting, or we
There is a recent paper from Korea looking at root tear, simultaneous root repair along with HTO, and it's been found, and of course our experience also states that there is no role for root repair when you're doing HTO, because root tends to heal the moment it's offloaded. So I will not do a root repair along with HTO for someone unless it's a very acute root tear. So for example, someone I'm seeing a patient who's just had an episode of severe sudden pain in the knee joint with a root tear about 15 days back, and is a fairly active patient. My correction in osteotomy is about 5 to 7 millimeters only, then I would not hesitate to do a root repair along with my HTO. But generally speaking, for a standard patient with varus arthritis in the knee, I will not do a root repair simultaneously. ACL tear and PCL tear are not contraindications for HTO. We just need to learn to play with the slope of the tibia. So a person who has an ACL tear, I would flatten the tibial slope. That means if this is the anterior side, this is the posterior side, my slope is like this. I will flatten the slope that will stabilize the knee in an ACL deficiency, and I will increase the slope in a patient with PCL deficiency.
Okay,
so you need to learn to play with the slope of the proximal tibia for ACL PCL deficiency, and that too in a symptomatic patient with instability, not for normal patient.
So, sir, we'll be taking two quick cases. This is the case of hinge fracture. We got some questions in chat box about the hinge fracture. This is the case, 55 years female. We did high tibial osteotomy without graft. Intraoperative postoperative period was uneventful, and 2 weeks X-ray showed type 3 hinge fracture. So, what's the problem? How common is this, sir?
So, in my opinion, type 3 hinge fracture is easily missed unless you are very vigilant during the surgery. Of course, I've had that. I've had about 7 or 8 hinge fractures in my 20 years of HTO. So it's not an uncommon thing. Fortunately, I won't say fortunately. I am very vigilant, and I'm always looking at the CM image very carefully. Now, see where the hinge point is. Can you get your arrow on the hinge point? Yeah, so the hinge point has to be somewhere there. Now, see where the osteotomy is opened till just about 1.5 centimeters below. So the opening of the osteotomy should have happened somewhere at the hinge point, but it's happened about a centimeter before that. That is a classical indication that you have got a hinge fracture, which is sometimes not visible. When you're opening your osteotomy, go very slow. Always be vigilant to see if there is any sudden opening of osteotomy. What will happen when there is a hinge fracture? That osteotomy, the bone which was sort of resisting you opening it, suddenly just give up, and the osteotomy opens up easily. And for this, an easy option would have been to just pass a couple of 4.5 cancerous screws from lateral to medial side to hold the osteotomy, and that would have been very easy. So I'm interested, what did you do for this?
We just followed the patient. Patient was happy, sir. Patient was pain-free, and we are following the patient. And
this is a stable pattern. As long as you're offloading the patient, that means the patient is not weight bearing, this will not collapse.
Okay, thank you, sir. So, does this osteotomy hinge fracture relates with use and no use of bone graft or type of plates and also?
No. So I think your hinge fracture depends on the technique of your osteotomy, how you're opening it, how fast you're opening it, how much strength you're applying to open it, and whether you are done your osteotomy at the right spot with your hinge point at the right spot. So if you look at the position of your hinge, it has to be just at the level of fibula head, about 5 to 7 millimeters medial to the lateral cortex. If you get that level, then chances of hinge fracture are very low. Now you have to remember that the proximal tibia, I'm sitting in my clinic, so I have a specimen here. That's a knee replacement, I know, so ignore that. But let me take the patella off. So this is the proximal tibiofibular joint, and your osteotomy is going to be somewhere like that. Can you see that?
Yes, sir.
Now, if you look at the fibula head, the ligaments from the fibula form a nice support anteriorly, posteriorly, and superiorly. So your osteotomy is always well supported with good amount of soft tissue coverage. When you have that, chances of displacement of a hinge fracture are very less. That is why you need to get the osteotomy at the perfect spot with a hinge at the perfect spot, and generally works that way.
Okay, so last few questions, sir. Routine use of bone graft, how important it is, and the timing of weight bearing.
I think routine bone grafting is not important if you're using a locking plate. with a very secure fixation. I will not do a bone graft for everything. As I said, this is luxury. I get bone graft really freely available. That's why I use bone graft for most of my osteotomies above 10 millimeters opening. Anything less than 10 millimeters, of course, there is no bone graft required. The advantage of bone graft is you can weight bear that patient early. You can mobilize the knee early, and the bleeding that happens from the osteotomy is less. There's something called tamponade effect from the bone graft. So it makes life easy. Recovery is faster. Having said that, clinically, literature-based medicine, which is normally followed. So evidence, there is no evidence to show superiority of the bone graft in healing of the osteotomy and the ultimate result of an osteotomy. So bone grafting is not essential if you're using a locking system.
And what about the weight bearing, sir? Timing of weight bearing?
If you're happy with your fixation, if you're using a locking plate system such as Tomofix, the one I showed, I would weight bear the patient the next day of surgery. So I normally do it in the epidural, so I don't weight bear them on the same day. So I get them weight bearing the next day of the surgery or the second day of the surgery, and I allow them partial weight bearing for 2 weeks, and after that full weight bearing is tolerated.
Okay, sir. And what is your usual time when you see the bone formation when bone graft is not used, sir?
Normally 6 to 8 weeks. So in 6 to 8 weeks, you start seeing good healing happening in the osteotomy.
Okay, sir. So now this is the final question from chat box. How do you deal with the superficial EMCL during closure?
Yeah, that's a very good question. You saw how I released the whole of the MCL as a single layer along with the base fascia. I just let it fall back on the plate or under the plate, depending on the type of plate I use. You stitch it to the soft tissues on the front of the incision, so that it forms a covering on top of the plate. You don't reattach the MCL at all. So you just reattach the soft tissue, the base fascia, and that usually works quite well.
Okay, sir. Thank you so much. That was wonderful learning experience. Since the time is already, the clock has already ticked 8 p.m. So I think we will be stopping it. Thank you so much, Bhusan sir. I would like to request our president, Dr. Sudeep Baide, to give the concluding remarks. And Bhusan sir, if you have something to say about today's program, you are please.
That's a great thing you guys are doing in including realignment surgery in the arthroscopy work and knee work. And I hope this is one of our last online meetings, and we can all meet in person, maybe in Nepal. Why not? I will be more than happy to come and visit you guys.
Yes, sir. You are most welcome, sir.
Yeah, Dr. Bhusan Sabnis, that's a really wonderful thing, and we should meet in person. And on behalf of Arthroscopy Society of Nepal, I would really like to thank you very much. In spite of your really busy schedule, as I came to know about you, that you have managed some time for us. And I'm sure we had 32 participants. So most of their doubt must have been cleared. They will be started doing this surgery, and really thankful for your presence in today's meeting. I'm thankful to all the participants who participated here, and I'm thankful to Dr. Vivek Basukala and Scientific Committee, and Dr. Amit, who coordinated with Dr. Sabnis for this meeting. And I hope to meet all of you in next meeting. Thank you, Dr. Sabnis, and thank you all the participants for this clinical meeting and for your presence. Thank you very much.
Thank you, sir. Thank you, sir. Bando garom hai, sir.
Thank you. Yeah, thank you, Vivek.